What is going on? Today, we're going to be hitting the Nancy Caroline ninth edition textbook, going over chapter 16, which is airway management. Very long chapter. If you're in school right now, I'm sure you're shaking your head. The slides just for this PowerPoint is over 300 slides. So I'm going to kind of move through them, point at things that are important, maybe some concepts that will help you understand things a little bit better. When it comes to airway management, a lot of students do struggle with the idea of when am I just oxygenating a patient versus when am I actually ventilating the patient? Two completely different things. And these are some of the topics that we're going to be discussing today. Before anything, we always got to start with a little bit of anatomy. I'm sure as a student, you're used to that by now. So let's talk a little bit about it. Okay. Saying all anatomic airway structures above the glottic opening, which is located in the larynx, right? Anything that is above that glottic opening is known as an upper airway. Please know that. Anything that's above the glottic opening is upper airway. So, tongue, we could see here, tongues are large depending on the patient. Unfortunately, for airway management, some tongues do get extremely in the way. Okay. Especially when my patient's unresponsive. And I'm going to tell you this just from experience, some people's tongues are massive. So, getting good at opening up the airway, manipulating the tongue, maybe utilizing a device to kind of sweep it out of the way. We'll be talking about that in this lecture, will be beneficial for you. The uvula is that punching bag that you've noticed in the back of the throat. That is called a uvula. It says it extends from the soft palate and the posterior oral cavity and the to the base of the tongue. Um, so basically, that uvula assists with a gag reflex, right? When things get that far back into your throat, it can stimulate a gag reflex when it's by or touches the uvula. The pharynx extends from the nose and mouth to the esophagus and trachea. Okay, for those of you that are taking notes, please know that there's three different parts of the pharynx. It's the nasopharynx, oral pharynx, and the laryngopharynx. We can look at that from this previous photo. Okay, right here, the top part of the back of the mouth, right? We have that nasopharynx that's connected to the nose, back of the mouth. Oral pharynx, right here where the mouth is open. And then just below that, right above the larynx itself and the glottic opening, is that laryngopharynx. A lot of terminology. You get used to that with anatomy and physiology. This one is a very interesting, and we're going to be coming back to this little chart later on in this lecture once we start talking cricothyrotomy, right? But we need to know the thyroid cartilage and cricoid cartilage. Now, as a student, how I want you to memorize this is CT to the head. CT to the head. And what I mean by that is the cricoid cartilage right here is that first bump at the base, right? So if I take my finger, and for ladies, this might be a little bit harder for you to feel, but for men that have more prominent thyroid cartilages or Adam's apples, you'll be feeling this. The first bump that you feel, it's known as the cricoid cartilage. When you move up from there, you're going to feel another larger bump, and that's the thyroid cartilage. So CT to the head. Right in between that cricoid cartilage and the thyroid cartilage is something called the cricothyroid membrane. That membrane right there, in between those two cartilages, that is where we do perform a cricothyrotomy. And again, we will be going over that later on in the lecture. But remember that CT to the head. That'll help you memorize that. Okay, we talked about the cricothyroid membrane. We'll talk about it later. Now, the glottis. The glottis is this opening here, right? In between the vocal cords, we have a glottic opening. This is how we access the trachea. Your trachea is part of your lower airway, right? All these topics that we've been discussing here have been part of your lower airway, your actual trachea itself. And to access the trachea, we would have to go through the glottis, space between the vocal cords. You see in this photo, we have vocal cords kind of in that V pattern. And just above that, we had something called the epiglottis. Now, the functionality of the epiglottis is every single time you swallow, that epiglottis lays down and actually covers your glottic opening. So I'm sure if you've been alive, you have at one point or another inhaled food or inhaled water, right? What happens when that occurs? You feel like you're probably going to die, right? You start coughing, and that is completely normal because your epiglottis was not doing its job. So, whenever you swallow, the epiglottis again lays down and covers up that glottic opening so you don't accidentally inhale or bring water in the wrong pipe, right? We want that water and that food to go down the esophagus, not into the glottic opening into our lungs. Okay. Understand too, whenever they say the terms lower airway versus upper airway, I always want you to remember that lower airway goes all the way down into the capillary membranes of your lungs, so into the alveoli. That is considered a lower airway. So if you ever hear a lower airway obstruction, it's anywhere from that glottic opening down into the lungs. Anything above that is an upper airway obstruction. Looking here, it says respiratory and cardiovascular systems, they work together to distribute oxygen and to get rid of waste. Now, what waste are we talking about? Carbon dioxide, CO2. We'll discuss that a little bit. Please know some of this terminology. One of them is the term ventilation. Ventilation is the actual physical act of moving air in and out of the lungs. We know this as inhalation and exhalation. One thing I want you to remember about inhalation versus exhalation is a ratio. My inhalation should be, let's say if my inhalation was 1 second. This is the best way to memorize this. My inhalation was 1 second. My exhalation should be 2 seconds. We call this an IE ratio of 1 to 2. Okay. My inhalation, 1 second. Exhalation, 2 seconds. That is completely normal for a breathing pattern. And we'll get into some abnormal IE ratios when I talk about respiratory emergencies. Oxygenation, please know this term as well. Process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. Remember, your blood has multiple properties and it does a very important job. And one of them is to transport oxygen to tissues into your body, right? It says it requires adequate fraction of inspired oxygen. Remember, fractions of inspired oxygen is the amount of oxygen that's in the air. For example, if I say, hey man, the atmospheric air that's around me right now has approximately 21%, that's the FiO2 that I'm currently inhaling. If I put on a nasal cannula, might be able to bump that up to 44%. If I put on a non-rebreather mask, I might be able to bump that up to 95%, right? These are the FiO2s of that air that's the patient's breathing. Okay, taking a look at this process of exchanging oxygen and carbon dioxide is known as respiration. Again, for those of you who are taking notes, please write that down. Super important. There is uh, external and internal respiration. Let's take a look at those definitions. External is known as pulmonary respiration, exchange between the alveoli and blood in the pulmonary capillaries. So pretty important, right? Because why is pulmonary respiration such a big deal? Says I breathe in oxygen and I exhale carbon dioxide. I'm getting rid of that waste through that process. Internal or cellular respiration is the exchange between the systemic circulation and cells. Remember, these cells, through something called diffusion, allows for carbon dioxide to hop off the cells. That's kind of what this photo over here is showing, and oxygen to hop onto the hemoglobin. Let's talk a little bit more about that. Saying pathophysiology of respiration, maybe some disease processes that can occur in respiratory system. Disruption of pulmonary ventilation, oxygenation, or respiration can cause an immediate effect, right? And we're going to talk about some of those and how disrupting or interrupting one of those processes will make your patient deteriorate. And this is the first concept right here. I always like seeing this clock. It says every cell needs a constant supplies of oxygen to survive. Absolutely. Your body needs oxygen, right? Sufficient levels of external respiration and perfusion to basically transport that oxygen so it gets to all the tissues. Now, take a look at what this says. It says time is critical. 1 minute, you're after 1 minute of being hypoxic or having no oxygen, your cardiac muscle, your heart actually starts to become irritable. And an irritable heart can have a higher chance of throwing a cardiac dysrhythmia, right? It says 0 to 4 minutes, the brain, it says damage is not likely at by the 4 minute mark, but there starts to become an effect to your brain within that amount of time. At 4 to 6 minutes, brain damage is possible. 6 to 10 minutes, brain damage is very likely, and anything greater than 10 minutes, irreversible brain damage occurs. And remember, irreversible. And the reason why I like bringing up this chart, and I do like talking to students about this, is I always say if you saw somebody outside right now and they weren't breathing and you called 911, how long would it take for fire rescue to get there or EMS personnel, or however it works where you live? Um, if it takes anywhere over 5 minutes, which is, I would say, most of these systems, there's a really good chance that your patient's going to be have irreversible brain damage, right? There's a very likely chance that there's going to be brain damage to that patient because by the time the crew shows up, does an assessment, takes out the equipment, time is just ticking, right? And this is why hands-only CPR became such a big topic and saying, hey, man, we need bystanders to assist with patient care before EMS personnel arrives. Um, it's crazy how important oxygen is to these patients. Hypoxia. What is hypoxia? If you've gone through EMT school, you're very familiar. Tissues and cells do not receive enough O2. That's all it means. Lack of oxygen. Right. So let's take a look at some of these early signs. Got to know these uh, is when you start to see them, and when you get a little bit of experience in noticing them, you can make a quick decision to improve your patient's outcome. Early signs is restlessness, irritability, tachycardia, and anxiety. One thing I always tell students is when I used to fly as a flight medic and I would start going to altitude, some of my patients would start to experience anxiety, restlessness. They'd start taking the pulse oximetry off. They might start fumbling with their belt, whatever the case might be. And we would pay close attention to that to start increasing oxygenation when going to altitude. Something you might be able to see on your patients out in the field. Late signs, mental status change, weak pulses, and cyanosis. Remember, cyanosis is that change of color due to lack of oxygenation. Typically, we'll see it in the fingernails, around the lips first, and if it's severe cyanosis, we'll start seeing it throughout the patient's face, and other parts of their body. Mental status change is a very ominous sign, though, with hypoxia. Got to pay attention to it. Ventilation and perfusion mismatch. Um, Easy to discuss. Let me just go through this real quick. Air and blood flow must be directed in the same place at the same time. They're both working together, right? Ventilation and perfusion must be matched. Remember, where's that oxygen going when you breathe it in? It's getting diffused, right? We have oxygen jumping onto hemoglobin. And then where's that hemoglobin going? Well, my if I have good perfusion, that blood is being transported throughout my body. So there's a matching between the amount of breaths that I'm inhaling to the amount of oxygen that's being delivered throughout my body. That's called a ventilation perfusion ratio. If we call it a mismatch, okay, a mismatch means that they're not matching. It says if the VQ mismatch results, by the way, VQ is the abbreviation for ventilation to perfusion. I know does not mean perfusion in your head, but please write that down if you're a note taker. VQ mismatch means ventilation to perfusion mismatch. Blood passes over the alveolar membranes without gas exchange. So that means that there was a mismatch with the ventilations. There's no ventilations occurring, right? Or CO2 is recirculated, which then CO2 would be recirculated into the bloodstream. Problematic, right? CO2 is a waste. Your body needs to get rid of the waste. And the problem with a lot of CO2 in the body, there's going to be a byproduct called lactic acid that starts to develop, and then the pH starts to change within the patient's body, and now we have an acid base balance issue going on. Okay, more waste would start to develop within the bloodstream. It says factors that affect ventilation. Patient's airway is critical for the provision of O2 to tissues, and intrinsic and extrinsic factors can cause airway obstruction. Absolutely. Let's talk about intrinsic factors. Okay. An intrinsic factor that will cause an airway obstruction. We can say airway swelling, right? Maybe it could be lower airway obstruction or swelling from asthma, from COPD, from anaphylaxis. Maybe an extrinsic factor, external, might be choking on food, right? That's an extrinsic factor. We have to be mindful what these terms are when we take an exam because you might see this again. Let's just say that. Of course, is the next slide, that story of my life. Intrinsic factors, infection, allergic reactions, unresponsive. The tongue, always a test question, right? The most common obstruction in any unresponsive patient. Remember, that tongue, it was always getting in our way. This is why OPAs are such a great thing. With an oral pharyngeal airway, we can go ahead and sweep that tongue using a 90-degree method and keeping it from blocking the airway. Some extrinsic factors here. We did talk about the FBAO, or the foreign body airway obstruction. Also, they're saying trauma. Blunt or penetrating trauma can be considered an extrinsic factor that can cause an obstruction. Please, please, please write these terms down. Know them. Hypoventilation versus hyperventilation. First one, hypoventilation, carbon dioxide production exceeds elimination. Let me explain. Carbon dioxide. How do we get rid of carbon dioxide? We breathe. Remember, I said whenever you exhale, we blow off CO2. So let's say I'm hypoventilating. First off, you got to know what hypoventilation means. Hypoventilation means inadequate breathing. Tests love to use the term shallow. Shallow breathing is hypoventilation. So let's say that I have inadequate breathing. By the way, before I even jump to my example, please know that a respiratory rate has nothing to do with the quality of breathing. Just because I say somebody's breathing at a rate between 12 and 20, which is a normal adult respiratory rate, doesn't mean that the quality of the respirations are adequate. So someone might have a respiratory rate of 18, but they might still be hypoxic. They might still have uh, poor capnography, right? These are all things that we need to understand, that the quality of breathing outweighs the rate. There are some rates, though, that are really bad. We'll get to that. So with hypoventilation, we know that I should be blowing out my CO2. But what happens if my breathing is so inadequate that I'm not getting rid of the CO2? It's just going to keep stacking, stacking, stacking in my body, right? And now my carbon dioxide levels, my end-tidal capnography, is going higher and higher and higher. This is known as hypoventilations. Carbon dioxide production exceeds its limit elimination. I should be eliminating it. For those of you taking notes, remember a normal end-tidal capnography is 35 to 45. So anything that is greater than 45, we're always suspecting hypoventilation. Next, hyperventilation. I think most people here know that hyperventilating just means I'm breathing really fast. The quality is really strong ventilations, and I'm blowing off too much CO2. Okay, it states carbon dioxide elimination exceeds its production. Again, 35 to 45 is normal. Anything less than 35, I'm always, always, always considering hyperventilation. Pay attention to the patient. The reason why I'm saying that right now is in EMS, we do see a lot of low end titles. Okay. But there are other causes, metabolic causes, not respiratory, that can lower my end tidal capnography. This is not technically a class on end tidal capnography, but understanding these two, hypo and hyper, does help with knowing that part of respiratory acidosis versus alkalosis. I hope that helped. Some other factors affecting oxygen and respiration, factors in ambient air. Love to see it, right? High altitudes, partial pressure decreases. Have you ever, and this goes out to my sea level people, have you ever traveled out west or gone to yeah, we'll say to somewhere where that's high elevation? Maybe you flew into Denver, Colorado. Um, did you notice how tired you got just walking up the stairs? Have you ever heard somebody say, "Gosh, there's not enough oxygen up here"? I'm sure you have heard that at one point or another. And believe it or not, they are wrong about that. It has nothing to do with the amount of oxygen because our atmospheric oxygen is the same no matter where you go. Okay. It's about 20.8. Everyone always says they round it up to 21%. So 21% is pretty much everywhere. But when I am at altitude, what happens is barometric pressure changes, it drops, right? I have a partial pressure decrease. And when we talk about my body, it acclimates to a pressure. So if I live here in sea level and diffusion's occurring, right? Oxygen is hopping onto my bloodstream or onto my hemoglobin and my I'm blowing off CO2 and it's normal occurrence every single day. Now all of a sudden I fly for a couple hours and I land somewhere where the partial pressure is different and my body's not acclimated to that partial pressure. My body has a hard time at adjusting, okay? Even though my respiratory rate might have stayed the same, we have somewhat of a mismatch going on because of pressure change that occurred. Pretty interesting. In closed environments, it's saying that oxygen can decrease. We've seen this a lot in manholes and sewer systems where people go down without a breathing apparatus like an SCBA and they go unresponsive due to hypoxia. So that can happen as well. There are some toxic gases that will displace oxygen within an environment. A really popular one that a lot of people like to talk about is CO or carbon monoxide. Some internal factors here. It says conditions that reduce the surface area for gas exchange also can decrease oxygen supply. So conditions that reduce the surface area for gas exchange. Okay, this could be from fluid in the lungs, maybe airway swelling, right? Now we're getting into CHF, inhaling toxins, asthmatics, COPDers, right? A lot of these different respiratory emergencies that can reduce surface area for gas exchange. Okay. Right here, fluid in the alveoli inhibits gas exchange. This can happen with submersion victims or drownings. Patients with pulmonary edema, kind of talked about those. Occupational hazards, we were saying, inhaling toxins. One thing that you got to know is there's something called surfactant. Surfactant is a kind of like a lubrication on alveoli that allow for alveoli to expand and contract, right? Because these alveoli is where that capillary blood is and the lower airway. And this is where that diffusion takes place in the alveoli, lower airway. And when you have this surfactant removed, or we call it washed out from submersion, from pulmonary edema, these patients have a really difficult time with gas exchange, right? They even have something called atelectasis or collapsing of the alveoli. Some other factors that can affect respiration, hypoglycemia. Okay. It says oxygen glucose levels can decrease with hypoglycemia. The very famous looking patient that's hypoglycemic is snoring respirations. They have a lot slower, right? Bradypnea, slower respiratory rate. Infection, okay, says increases metabolic needs and disrupts homeostasis. Absolutely. These patients have, they suffer from metabolic acidosis. Hormonal imbalances, such as DKA. Typically, with DKA, we see something called Kussmaul respirations, or really fast, rapid breathing, deep, rapid breathing, rather. Some circulatory compromise. This is something that a lot of students kind of don't think about. And the reason why I say they don't think about it, it's because whenever you think respiratory, you're so focused on airway. Is my patient breathing? Is my patient exhaling? Are they breathing adequately? Well, remember, how does oxygen get around your body? Through the circulatory system. So if we have a compromise to the circulatory system, is it possible that my patient could become hypoxic? Absolutely. Okay. So inadequate perfusion, such as shock, oxygen demands will not be met. Obstruction of blood flow is typically related to trauma and inhibits or stops gas exchange at a tissue level. Not good, right? I know this is not a trauma lecture, so we're not really going to get into crush syndrome and all that stuff, but that's kind of where they're going with that. Heart conditions that can reduce blood flow to tissues, the discussion of congestive heart failure. This is where that comes into play, and that will be later in the lecture. Blood loss and anemia reduce the blood's oxygen carrying capabilities or abilities. And we did kind of discuss shock already, not being able to deliver that blood effectively or efficiently to the organs that require life, right? And all organs that require life need oxygen. Okay, talking a little bit about acid-base balance um, through respiratory, mainly here. It's talking about hypoventilation versus hyperventilation. Remember, I did discuss carbon dioxide elimination. Remember, if I have a patient who is not breathing or hypoventilating, my patient is stacking their CO2. When you stack your CO2, remember, it's going to be greater than 45. My patient, their pH is going to drop. Okay. Please just write that down in your notes. If I have a patient who is not breathing, you could write hypoventilation equals CO2 greater than 45, which then will cause a pH to drop lower than 7.35. Just remember, a normal pH is 7.35 to 7.45. And when we have a drop in pH, this is called acidosis. So, how do we term this? Respiratory acidosis. Hyperventilation is the exact opposite. My patient's breathing off too much CO2. They're getting rid of it. So I'm going to have a CO2 that is lower than 35, but my pH is going to be greater than 7.45. This is known as respiratory alkalosis. It says the respiratory and renal systems help working together to maintain homeostasis and trying to maintain my pH balance to neutral. Remember, neutral is 7.35 to 7.45, and my body is constantly trying to maintain homeostasis. It's that balance of life. Okay. It says acid in the body can be expelled as carbon dioxide from the lungs. My kidneys are going to do a very good job at creating a bicarbonate to try to buffer this acid as well. And also, my respiratory rate can increase to try to blow off more CO2. So they're working together to try to rid of acid. Okay. It says acidosis can develop if respiratory function is inhibited. Remember, we said when your patient's not breathing or hypoventilating, that is respiratory acidosis. And then it says alkalosis can develop if the respiratory rate is too high. Please know that. Don't forget it. Get into metabolic acidosis another time, because this is all about respiratory. All right. Assessing airway and ventilatory status, something that takes a little bit of skill and takes some experience. But please, for those of you who are in school, pay attention to your patient's respiratory rates and quality. I think we all know what shortness of breath looks like. Okay. If you've ever watched team sports, if you ever played team sports, I'm sure at one point or another, when you've ran as fast as you can, you've probably ended up in a tripod position trying to catch your breath. That is a sign of respiratory distress, right? Something that we've seen by just looking at somebody's physical appearance to say that that person's short of breath. Determine the patient's airway is patent. If you've ever heard that term and you're like, man, I'm so confused what patent even means, it just means that air is able to go in and out without issues. A patent airway allows for inhalation and exhalation. If there's something blocking that, then the airway is not patent. For example, secretions pulling in the patient's mouth. Oof, bad. Okay, there's a couple of reasons why this is bad. First reason is obviously air is not coming in because there's so much secretions in the patient's mouth. Typically, we'll see blood, we'll see vomit, sometimes uh, just an excess of saliva or some sort of secretion. Understand that this could mean your patient has a absent gag reflex. Paramedics, paramedic students, if your patient does not have a gag reflex, this means your patient is not able to protect their own airway. If your patient is unresponsive without a gag reflex, we need to manage airways. Okay. The last thing you want is to lay this person back. During transport, the patient stops breathing and you're not prepared, right? It's better to just intubate the patient, manage the airway, ventilate the patient throughout transport and bring them to the hospital. Okay. Recognizing adequate breathing. This, again, can take a little bit of experience, but a extremely important skill to have, right? Is my patient responsive, alert, and able to speak? Are we able to have a conversation? I'm sure at one point or another, you might have seen somebody who's so short of breath that they can't talk. Okay. It's a dangerous first sign of potential respiratory failure. Is the respiratory rate between 12 and 20? Remember, 12 and 20 is considered normal. That does not mean that if there's a respiratory rate less than 12 or a respiratory rate greater than 20, that I need to ventilate the patient. Please don't mistake in that. Those are just normal rates. Okay. It's just normal rates. Adequate depth. We know usually when we see labored breathing, when you see somebody really working to breathe, um, pay attention to that. Or the patient is like altered and their breathing is very shallow and quick. We try to pay attention to these things, right? These are, we're trying to look for inadequacy of breathing. Breathing patterns, whenever they talk about breathing patterns, they're actually talking about literally the pattern of the breathing. What did I say our normal IE ratio was? 1 to 2. If my inhalation's 1 second, my exhalation should be 2. And it should be that way consistently. If at any point it becomes irregular, meaning I have a 1 to 1 IE ratio, now I'm apneic, then all of a sudden I start breathing what appears to be a 1 to 2, but it's really fast. Then all of a sudden it's really slow. And now I'm not breathing again. And it's just all over the place, erratic. This is considered an irregular breathing pattern. And irregular breathing patterns could indicate intracranial pressure, right? We might be talking a little bit about some of those patterns later. Next, we're checking for clear and equal breath sounds or lung sounds, right? One thing I really try to point out, especially to students, if you guys are doing scenarios, if you guys are practicing, and let's say you're running a scenario or you walk up to a patient who appears to have shortness of breath. Obviously, the first thing I want to know is what's the rate, rhythm, and quality of the breathing. Again, rate, rhythm, and quality. How fast are they breathing? Is the rhythm normal, that 1 to 2 IE ratio? And what is the quality? Is it labored breathing? Is it shallow breathing? Okay. I want to know this first. Next, part of my focused exam on this patient's respiratory is what's the lung sounds? Do I hear adventitious lung sounds? Fancy word. Whenever you see adventitious lung sounds in a test, please know that that just means irregular lung sounds such as wheezing, rhonchi, rales. These are adventitious sounds that you can hear in lungs. So I'm listening to the lung sounds. Always check the back if you're having a difficult time, right? Next, I want the capnography. Can I see if my patient's blowing off too much CO2? Are they withholding CO2? This is going to help me diagnose the respiratory issue or the quality of this person's breathing. Trust me, we don't just look at people and be like, hypoventilations. I wish it was that easy. It's not. Capnography is probably your best friend. Seriously. Um, Pulse oximetry is good sometimes. Uh, Typically, if I'm doing a focus exam on somebody's respiratory system, yes, I do want a pulse oximetry, but I don't completely rely on my SpO2. There's a few reasons why. One of them being that the SpO2 is just not reliable. If my patient has cold hands, my patient has poor perfusion, if depending on the lighting inside of the truck, whatever the case might be, it can throw off my pulse oximetry. So please, please, please use in-title capnography. It's going to make your life a lot easier. Breathing rate fewer than 12 breaths per minute or more than 20 breaths per minute can be considered inadequate. Okay. What we need to look at the big picture. Okay. Cyanosis, indicator of low blood oxygen content. Absolutely. That is 100% an indicator that I'm looking at. Is my patient cyanotic? Like, and how bad's the cyanosis? Is it cold outside? Right. I need to play detective a little bit. Please don't just jump on cyanosis and the fingers thinking immediately that this person needs to be bagged. How this works. Prefer, preferential positioning. Upright sniffing, tripod position. Okay. Upright sniffing typically means that the person's having a hard time swallowing. Typically, this is seen in children, right? When they're leaning forward and drooling. That is an upright sniffing position. Tripod position is when the person positions and they're putting their hands kind of like on their knees or legs, and they're expanding their chest wall kind of with their arms to allow their chest wall to allow for more inflation of their lungs, right? And they're using kind of accessory muscles to uh, help open their airway, basically. Some potential causes of inadequate breathing could be an infection, trauma, brainstem injury. Remember, your medulla is where that actual respiratory rate comes from. So there could be a problem with the brainstem. Noxious or oxygen poor environments, renal failure, right? There's a lot of different things that can cause inadequate breathing. So now it's talking about airway management steps. Open the airway, clear the airway, assess the breathing, and provide appropriate interventions. Now, this is where reading stuff here in the textbook and being realistic with you kind of changes a little bit. And what I'm getting at is, let's say you walk up to a patient who is altered on your stretcher. Okay, they're altered. Obviously, they're not answering your questions appropriately, and they're breathing at a rate of 28 breaths per minute. Okay, they're breathing at an inadequate rate. They're altered. We might as well intubate them, right? We might as well ventilate them. Figure out why this patient is altered. Okay, I can't stress this enough. If I look at this person's pupils and I see that they are either constricted or fixed and dilated, I might say that this patient could have altered mental status due to a overdose, right? And I could try to reverse that overdose. If I'm thinking that this patient is altered because of a blood glucose change, okay, I need to change that. I'm not going to just ventilate somebody because they're altered and they have a fast or slow respiratory rate. I need to do my due diligence to find out why. Now, understand this as well. Let's say I walk up to somebody and they have obvious pinpoint pupils, but their breathing rate is 6. Do you think I'm going to withhold oxygen from that patient to give them Narcan? No, I'm going to start ventilating the patient or providing oxygen therapies to that patient while I get my medications ready to be delivered. So please, we have to look at the big picture on how my patient's presenting. Let's look at everything. If I see that my patient has an altered respiratory rate, I might want to do a little bit deeper of a dive to say, hey, is this patient breathing adequately or not? Remember, SpO2, end-tidal capnography, lung sounds. I need to check these things to make decisions. Okay. Note the following, right? We're still looking at inadequate breathing. Position. How's my patient position? And this is so important with our respiratory patients because of that second word there called orthopnea. Orthopnea is dyspnea or shortness of breath with patient positioning. For example, some people suffer from something called positional nocturnal dyspnea, also known as PND. When this patient lays down to go to sleep at night, they get woken up with shortness of breath. This is a bad sign of heart failure, right? Pulmonary edema. PND or orthopnea typically is a sign that this patient needs to sit up. They need to be at high Fowler's position to breathe adequately. Be mindful. Whenever you run a patient and they are short of breath, sit them up. Your obese patients will really thank you. Your patients that have edema will really thank you. I'm telling you now, sitting people up in a high Fowler's position makes it a lot easier to breathe. Okay, take a look for chest rise and fall. Look for adequacy of chest rise. The skin color. Absolutely. Is it pale? That's telling me that this patient has poor perfusion. Remember, your blood carries oxygen. Flared nostrils, nasal flaring. Okay, that means that the patient's starting to use accessory muscles, and you actually see their nostrils flaring to get air in. Pursed lips. Typically, if you see somebody breathing through pursed lips, they're creating PEEP, positive end expiratory pressure. Right, this patient's requiring an extra amount of pressure to maintain alveoli adequacy, right? For that, remember I talked about atelectasis earlier and keeping those alveoli open. If people are doing pursed lip breathing, it's usually because they need PEEP and they're creating their own. They don't even know it. Retractions, that's usually when you'll see accessory muscle use throughout the chest. Very commonly seen in kids with respiratory distress. We'll see literally, you'll see their rib cage while they breathe, the retractions within their chest. Asymmetrical chest wall movement, that's not a good sign. That's usually seen in trauma, getting more into like a flail chest segment. Quick breaths, long exhalations, we call that prolonged expiratory phases. We'll be talking about that in respiratory emergencies. That's typically seen in our lower airway obstruction, asthma, COPD, anaphylaxis, and then labored breathing. We all know what that looks like. A lot of the same stuff here. All right, talking about a breathing pattern. Let me shrink myself here. Couple things on this slide that you have to know as a student. Okay, you'll see it again, I promise. Um, First one, let's talk about Shane Stoke respirations, just because it's here on the slide. Remember we talked about a pattern, an IE ratio of 1 to 2. If my inhalation is 1 second, my exhalation should be 2 seconds, and it should be a normal pattern. Just breathe in, breathe out, breathe in, breathe out. Well, take a look at this. This is called Shane Stokes breathing. And Shane Stokes breathing, this is typically from a neurologic insult, right? So it's uh, a disruption of the nervous system. It could be a brain injury or ICP, but it's causing this pattern to get thrown off, right? Your breathing pattern gets thrown off. And what this picture is trying to show, this line here in the middle is apnea. So the patient's not breathing. Now the patient starts breathing slowly. They start breathing faster and faster and faster and faster, and then they start breathing slow again. And then they go into apnea. And the pattern keeps occurring over and over. Periods of apnea with bradypnea, tachypnea, bradypnea, and then back to apnea. Okay. So it's a pattern that continuously happens. Definitely different than biots or ataxic respirations, which is completely erratic, right? It does not have a pattern like this one. So please know the difference between the two. Next thing I wanted to talk about that is on this slide that I think is important to know because you'll see test questions about it is pulsus paradoxus. Good luck assessing pulsus paradoxus out in the field. But if you're taking an exam, I would know what it is. A systolic blood pressure that drops more than 10 during inhalation. This is typically seen in your obstructive shock patients. Obstructive shock. So talking tamponade and talking bad tension pneumothoraxes. Okay. This is when you will see this pulsus paradoxus. Those of you taking notes, I would 100% write that down. It says ask about the evolution of the current problem. 100%, right? Typically, when we have a chest pain patient, what's one really important question we ask? What were you doing when the chest pain occurred? There's no difference with shortness of breath, right? If we're noticing an inadequacy in breathing, we got to say, what caused it? What were you doing when this occurred? First thing that gets brought up here are triggers, right? Onset, trigger, duration. Um, what can cause or what can trigger shortness of breath? Well, for some people that are asthmatics, it could be pollution, it could be maybe a perfume, maybe it could be pollen in the area, whatever the case might be, but these can be triggers that can cause shortness of breath. Remember I said the patient that has PND or positional nocturnal dyspnea, maybe that triggered the shortness of breath. But we need to be able to ask, when did this occur and what were you doing when the shortness of breath started? It says interventions, previous hospitalizations. Interesting questions because typically when you have a patient that has shortness of breath and they've had this before, they're kind of, I don't want to say relapsing, but they're kind of going back to what happened last time? And I hate to say this, but typically when you have a patient that has asthma and they tell you, oh, yeah, well, whenever I have a bad asthma attack, I get intubated. I go to the hospital, I get intubated. Well, the likelihood of that patient getting intubated in your truck at that moment is very high, unfortunately, for that patient with shortness of breath. Um, so it is very smart to ask for what interventions were done previously and have they been hospitalized for uh, the same issue. Are they taking your medications? Are they compliant with the medications? That's what that's asking. Absolutely. Very important questions to be asking our respiratory patients. Evaluate protective reflexes such as coughing, sneezing, gagging, sighing, hiccuping. Okay. All different things to assist, believe it or not. Well, not all of them, but sighing, hiccuping, um, yawning. Some of these things are to assist with opening alveoli, but coughing, sneezing, gagging, uh, maybe the coughing and the gagging are more of like a reflex to protect your airway. So patients that are unable to cough, unable to gag, these are patients that we pay very close attention and that we need to be maintaining their airway for them because they can't do it themselves. Okay, auscultating breath sounds. Get myself out of the way here. Auscultating breath sounds. The one thing that I do want to point out is locations of where you place your diaphragm of your stethoscope. Um, this goes out to the students, and believe it or not, all providers that are out there. If you do not practice lung sounds, do not expect to be good at them. It's as easy as that. Um, if you can see in this textbook where they're placing that stethoscope is not on any large bony prominence. And what I mean by that, you'll never see somebody place a stethoscope over the sternum. Why? Because you want to listen to lung sounds. Okay. You want to go in the best location to which you will be able to hear the lungs. If you put it on a bone, it makes it very challenging to hear the lungs. So even there in the back, if you look on the photo on the end there, they place it between the scapula and the actual spinal cord itself. There's a very skinny area in which you can listen to lung sounds along the back. How often have you seen providers just put the stethoscope on the patient's back and listen to the patient's scapula? Very challenging to hear lung sounds there. So again, this is going to take practice, and it's you got to be doing this on all your patients, especially you students. Whenever you guys do a ride, you do a clinical, you're doing some sort of evaluation, maybe you're practicing at home. Please, please, please listen to lung sounds. That's how you get good at it. Okay. Oh, of course, IE ratio comes up. Now, some normal breath sounds, some definitions over here. Tracheal versus bronchial vesicular versus vesicular. I would take a look at the definitions of each one of those. But really, what I'm trying to pay attention to are my adventitious or irregular lung sounds. These are all normal breath sounds depending on where the breath sound is being heard. Now, I know I mentioned IE ratios before, but what's the difference between if I have a short IE ratio, like a 1 to 1, versus a prolonged IE ratio, like a 1 to 4? Um, well, right here, it basically explains it. Expiration is prolonged with lower airway obstruction. So if you've ever had a wheeze or if you ever heard a wheeze, it's a prolonged expiratory wheeze. So they would have like a inhalation takes 1 second, but to get the air out can take 4 seconds. Okay, that's prolonged expiratory phase seen in wheezing. An expiration that is short is with tachypnic patients. Typically, when I see somebody who's hyperventilating or I see somebody with something like uh, pulmonary edema, I'm expecting more of a 1 to 1 ratio, very short. Breathe in, breathe out, breathe in, breathe out. Okay, talking about pitch, write these down. Okay, higher or lower than normal. Okay, Talking about stridor or wheezing. Intensity of the sound will depend on the airflow rate, consistency of the flow throughout inspiration, patient positioning, and the site selected for auscultation. And I like that they write that there, site selected for auscultation. Whenever I think stridor, I think inspiratory stridor. Whenever I think of wheezing, I think expiratory wheezing. If I am listening for stridor, I should be taking the diaphragm of my stethoscope and moving it up closer to the upper airway. If I'm listening for lower airway obstruction, I should be listening to the lungs. Okay. Here's some adventitious sounds or abnormal sounds. We got wheezing, rhonchi, crackles. Crackles is also known as rails, by the way. Stridor, pleural friction rub. Wow, and they don't go into depth on talking about each one. And the reason why they don't do that is because we're going to be discussing this in respiratory emergencies. So I will wait to do that there. Quantifying ventilation and oxygenation. Let's do it. Right off the rip, talking about pulse oximetry. I think I pretty much hit that enough. You guys understand why I don't really care too much for it. Not saying it's a bad tool. I'm just saying that we can't rely too much on it. It's going to put you in a tight spot. Okay, it's saying pulse oximetry monitors oxygenation status during intubation attempt or suctioning, identifying deterioration in a patient with trauma or cardiac disease, can identify high risk patients. All good stuff, right? I would never tell you that we don't or I don't put pulse oximetries on my patient. Every single patient I have has a pulse oximeter on it, and I do rely on it until I do a full assessment. And there are times which I find some discrepancies in my pulse ox reads. So be mindful that that's out there. Of course, next slide, right? Erroneous readings may result. Um, so this is just saying that what can cause a poor reading on your pulse oximetry? Bright ambient lights, patient moving, poor perfusion, nail polish, venous pulsations, abnormal hemoglobin. A lot of problems there. Okay. Talking about hemoglobin saturation, typically we don't, I'll be honest with you, in EMS settings, we don't look for hemoglobin level, right? Getting into like hematocrit and other blood work that they would do in the hospital setting. We don't really check for that in the back of a truck, but we do have the capabilities of looking for CO. Especially if you're planning on working for a fire department. CO has become like a really big topic on structural firefighting and maybe even extricating people from a burning vehicle. We're always looking for CO readings. CO is just telling us how much carbon monoxide is bound to the hemoglobin. Okay. So it reads just like a pulse oximetry would. It goes on the patient's finger. It looks identical to a pulse ox, but we can read CO levels. Peak expiratory flow measurement. I'm sure you guys have done this type of test before where they tell you to breathe through this fat tube and they get to keep exhaling, keep exhaling. You feel like you're going to pass out. Yep. Um, that's what they're trying to typically measure for peak expiratory flow. Um, there's certain exercises that they do for people that struggle with respiratory disease to improve peak respiratory flow. Now, I would say expect at least 2 on your boards exams. You know exactly which one I'm talking about. If you're trying to be a paramedic, um, I would expect at least 2 of these type of questions. So, with regards to arterial blood gas analysis, the first thing I would say is know what normal values are. Okay. Normal values, for example, of pH, neutral. I've talked about this already, 7.35 to 7.45. PaO2 is partial pressure of oxygen. is normal range is anywhere from 75 to 100. HCO3 is bicarbonate. That's 22 to 26. And then SaO2 is pulse oximetry. That's anywhere from 94 to 99. It's technically considered normal. Um, I would know those values. And to get really good at answering ABG questions, you're going to have to do some practice. And the one practice that I think is the best is the Rome method. Rome method, it's ROME method. Rome stands for respiratory opposite, metabolic equal. Okay. Um, I'm not going to do examples here, but there's plenty of videos out there of the Rome method. I might also do my own ABGs practice quiz and going through different questions using the Rome method and showing you how easy it is to use. This is probably the best method of answering these type of questions on your exams. But I am moving on. In tidal capnography, I'm a big fan. I'm a big fan. Detects carbon dioxide of exhaled air, 35 to 45 millimeters of mercury. Again, this is how I know if my patient is breathing adequately. Good end-tidal numbers. And it says capnography will indicate how adequate my patient's perfusion is, the effectiveness of chest compressions, and even if I have return of spontaneous circulation. Awesome. Okay. And what's interesting is none of those were respiratory related. I love it. Okay. Metabolic issues. Okay. Having to do with perfusion. But absolutely. Capnography is a great use for all three of those. Increased reading expected with inadequate ventilations. We talked about that with hypoventilating. It states low reading, expect fast respiratory rates in hyperventilation. And then it says perfusion generated by chest compressions to resume CO2 production and increase in tidal capnographies. Typically, when we see a sudden spike in end-tidal capnography during CPR, that is indicated or typically seen in ROSC, right? If I have a CO2 of less than 10 during chest compressions, it means I have poor quality chest compressions. I always want to be above the number 10 millimeters of mercury. And then when I have that sudden spike, I need to assume that we have ROSC. Okay. It says low end tidal despite adequate chest compressions could mean that the patient has severe acidosis, minimal CO2 return to the lungs. A lot of different reasons that can cause this. Um, could mean poor blood flow, even with good chest compressions. Could be from cardiac tamponade, right? Uh, we definitely can see how some issues can conflict with blood flow during CPR. It says end-tidal capnography monitors detect CO2 in exhaled air, colorimetric, digital waveform technologies. Waveform and digital end-tidal capnographies is more of like the standard nowadays. If you've ever seen a colorimetric system, it used to be a device that they would put on the end of a tube, and while you bag your patient, it either turned purple or yellow. And the easiest way to remember which one's good and which one's bad is I always say purple poor, yellow yes. Purple poor, yellow yes. So we kind of knew if our end titles were low or in the normal range. This photo here shows a end title capnography showing a numeric reading. What with this is a digital reading, but there is no waveform. Okay, not the best. We want to see waveform capnography. So this one is just digital, just giving us a readout number wise. Still better than colorimetric. If you've been around for a little bit and you've used end-tidal capnography, you may have seen this guy here. Okay, this is what we call non-intubated end-tidal capnography. Uh, Also, we can give oxygen through it as a nasal cannula. This little prong thing here at the bottom, here I'll move myself over so you can see me point. This guy right here sits over the patient's mouth, and as the patient exhales, that's how it collects the data. This orange piece connects to to our monitor, okay? And that's how we get the reading on the monitor. It's got to calibrate first without putting it on the patient, and then once it calibrates, we place it on our patient, and we're able to obtain waveform capnography. This is called intubated capnography. Again, waveform digital capnography. We place this piece on the end of our intubation, or technically, I mean, when we put it on a supraglottic airway, yes, there's not a lot of evidence saying that it's completely accurate, but you sure. But we could place this on a device, and while we bag our patients, we are getting end-tidal readings. Just make sure it's plugged into the monitor. All right, we got to get into talking waveform. For my note takers, let's do it. Make sure you are writing this out. Getting good at drawing waveform capnography is going to help you when you are on the road and you have a patient and you are looking at waveforms. Now, again, we talked about IE ratio, and that's going to get brought up in this discussion. But let's take a look at the phases. Phase one, A to B. A to B. This is known as an initial phase of exhalation. So exhalation is occurring. Okay, exhalation is occurring. The inhalation has stopped. Your patient is starting to exhale. That is A to B. From B to C is the expiratory slope. Remember, this is my patient breathing out. So they started to exhale and they're exhaling. That carbon dioxide level's increasing, increasing, increasing. C to D, we're getting an expiratory alveolar plateau. So right above me here, that right to is where this peak is. This is the highest level that end tidal gets. We call this the end tidal capnography. Again, the highest point of the peak of my capnography reading or my waveform is called the end tidal capnography reading. This is where that number comes from, where I say, hey man, 35 to 45 is normal. That little dot right there is what's giving me the reading, that location. Phase four, inspiratory downstroke. Remember, I said my inspiratory phase is what? 1 second. My expiratory phase should be 2 seconds. So look how short my inspiratory downstroke is. That's the patient inhaling. And look how much longer my exhale was. Inhale, exhale, inhale, right? Much quicker than the exhale. That's normal. So it's saying waveform duration, the width is telling me a duration of time. It's kind of like EKGs, right? When I'm looking from left to right and I'm seeing the length of that respiratory phase, it's telling me the duration of which that patient is exhaling. So if I see a very long waveform, it's telling me that I have a prolonged expiratory phase. I'm expecting to hear wheezing, right? I'm expecting a very long, drawn out exhale. Space between the waveform equals the respiratory rate. So as those waveforms get closer and closer together, right, my patient's breathing at a faster rate. Couple examples here. Let me get my head out of the way. So the first one up top, we look at this one up top, we're looking at a really high end tidal. So look how big those plateaus are. And then also, let me move myself just so I can show you what I'm talking about. Look at this number, 50. So that means 50, if I draw a line straight through this end tidal, that's where 50 would be, right? So this end tidal by itself is probably like in the 60s, super high end tidal. We said 35 to 45 is considered normal. And look how spread apart these respiratory or respirations are, right? So this patient is hypoventilating. They're not getting rid of enough CO2. The patient is suffering from something called bradypnea, right? Slow breathing. and they are withholding way too much CO2. If I was in the back with a patient and I saw this on my monitor, we would be ventilating this patient. They're not ventilating appropriately on their own. We need to take over. Bad signs. This one down here, the opposite. Look how much closer these respirations are to each other. So I know my rate is a lot faster. And where it says CO2, that's my halfway point. That's 25. Remember, normal is 35 to 45. So my end tidal should have been up here a little bit higher, but it is all the way down here, telling me that this is at around 15 to 20, right? Millimeters of mercury. Way lower end tidal. And seeing how fast this person's breathing, it's telling me that they are hyperventilating. They're blowing off too much CO2. This is when we start to look for our physical changes on our patient, right? Maybe they have something called carpopedal spasms where they're actually clenching their fists, right? These patients, they start to, they pass out, they get really anxious. We help them breathe, right? We have to coach these patients to slow down their breathing. There's a few different techniques I will show you um, to get these patients to relax. Abnormal capnographic waveforms. It's saying rebreathing, previous exhaled CO2, inadvertent extubation, tubing obstruction. These are all different things that I'm looking for that can alter my end tidal waveform. Okay. Obviously, if somebody's rebreathing too much CO2, what do you think is going to happen to CO2? It's going to go up. Not saying that rebreathing CO2 is always a bad thing, but rebreathing CO2, this is why if you've ever heard of, oh man, make them breathe through a paper bag, there's no medical professional who carries around a paper bag and has people breathe in it because rebreathing CO2 is actually dangerous and you can rebreathe too much CO2 and yeah, become hypercarbic. So we don't do that. Inadvertent extubation. Obviously, if we had waveform capnography and somebody extubated the patient, you would see this waveform go to a flat line and you would lose the waveform. So that's a great way to monitor your tube placement whenever a patient is intubated. Same with tubing obstruction. Sometimes we'll have different notching or different shapes of those end titles, and it's telling us that something's not quite right, and we have to look or inspect the tube, and maybe you might have to suction. At any point in this lecture, please feel free to just write comments on this video. It's literally, if you write comments on here, it helps uh, algorithm to share the video to get more traction on it, and also I can help answer any type of questions you have about the subject. Hopefully, this has been helping so far. All right. Patient airway is essential. I think we know that by now. Removal of obstructing material, tissue, fluids from the nose, mouth, and throat. This is all 101 airway management, right? We have to be able to manage the oral pharynx to allow the patient to effectively ventilate. Positioning of the patient. This position that you see right above me is called the recovery position. Typically, we put a patient in the recovery position when they are unresponsive and we are a little worried about their status of their respiratory management. Meaning, if that patient vomits, is there a chance that they will drown if we lay them supine? So typically, we always say to people, if you are with somebody out and a lay person, or you are not at work and you see somebody who's drunk that's laying on the ground, it's a very good idea to lay them on their side, not on their face, not prone, but in a recovery position and call for help. Okay. Mhm. If an unresponsive patient has a pulse but is not breathing, open the airway by performing a head tilt chin lift. Head tilt chin lift requires two hands, one hand on the forehead, one hand on the chin, and we lift up, kind of like hyperextending the patient's head back. Um, by performing this head tilt chin lift, this indirectly takes the tongue and moves it away from the trachea, allowing air to flow freely without the tongue's interruption. Remember, we said the tongue is the number one obstruction in the airway. Now, one thing about this technique is exactly what it says here: preferred technique with patients who have not sustained trauma. So, with that being said, do we know that this patient is unresponsive because it's not traumatic? If your answer is no, I have no idea why this person's unconscious. It's better to play it safe and do not perform the head tilt. Okay. If you're suspecting that it's a possible traumatic injury, maybe you might see a little bit of blood or you see a black eye or there's a bump or a hematoma on the patient's head, just play it safe and move on to a modified jaw thrust. Okay. I think we're good with head tilt chin lift. There's that modified jaw thrust. Okay. Or no, that right there, that's another head tilt chin lift. I'm sorry. Just going telling you exactly how to perform the skill. Very EMT type skill. It saves way more people than you'd probably expect. Usually, my really bad overdose patients, when we show up and the patient's hypoxic and they're cyanotic and the family's freaking out, usually one of the first things we do is perform a head tilt chin lift and the patient starts breathing, and people are always, it's like a party trick. People are amazed. All right, talking jaw thrust here. Suspected cervical spine injury. Again, you find somebody who's unresponsive. You're not sure what caused it. Um, this is a little bit more painful, performing a jaw thrust maneuver, but you hold the head still, right? And we're using our middle fingers typically, and we're placing the middle fingers under the jaw line and displacing the jaw forward without hyperextending the patient's head back. It's going to take a little bit of practice if you've never done one. I always recommend students not only to practice it, but to also have somebody else perform the skill on them. So you know exactly what it feels like and you know what displacing the jaw means. Um, yeah, recommend doing that. Believe it or not, the people that are probably the best at jaw thrusts are your lifeguards. Okay. Lifeguards are always practicing spinal and motion restriction. They perform jaw thrusts in the water while they swim and stuff. So usually the people that are most versed with that skill are the lifeguards. It says a contraindication of the jaw thrust is resistance to open the mouth. Because obviously, if the patient has what's known as Christmas, clenched jaw, you trying to displace the mandible, right, the lower jaw from the maxilla is going to be really challenging. It's not going to work out too well, and you're really going to be fighting it. So yeah, it wouldn't work. Saying some disadvantages: can't maintain if the patient becomes responsive or combative. Good luck maintaining either of them. Difficult to maintain for an extended time. Yeah, your fingers start to get sore, tired. Difficult to use with a BVM. Yeah, it requires two people. One person holding the jaw thrust, the other person squeezing the bag. Thumb must remain in place. Thumb typically holds the mouth open. Requires second rescuer, like I said. All good disadvantages. There's a photo of somebody using it. See where their thumbs are? Kind of like holding the mouth open while the other fingers are in the back of that mandible, displacing it forward. The tongue jaw lift maneuver is literally you're sticking your finger in there, holding the base of the tongue against, like, pushing it towards the mandible or the chin and lifting both up. Okay. It says place the hand closest to the patient's forehead, one hand on the forehead, just like with a head tilt chin lift. Other hand, reach into the patient's mouth, hook your knuckle under the gum line. Incisors or the gum line. While holding the patient's head and forehead, maintaining the hand, forehead, lift the jaw straight up. Yeah, putting my fingers inside somebody's mouth is kind of like a no-go. It's not going to happen. Last thing I want is this patient waking up and biting down on my finger. No, thank you.